myself, Dr. Yash Joshi. As a part of this academic talk, today's talk is role of TE in pediatric cath lab. As we all know, transesophageal echography has evolved from an intraoperative monitoring tool to a real-time procedural guidance. In pediatric cath lab, it plays a crucial role to delineate certain specific anatomy, to size the proper device and its proper positioning, hemodynamic assessment, any intra-procedural complications. It also reduces the radiation and avoids the unnecessary extra contrast. As in congenital heart diseases, where the anatomy is often complex and variable, TE is frequently determines the procedural success. Because of some certain pediatric consideration, which are like the heart is very small, there is a three-dimensional septal anatomy, multiple associated lesion, which are many times difficult to diagnosis on transthoracic echography. These pediatric patients are also very sensitive to radiations. There is limited vascular access, and there is precise need for the device deployment. TE helps for the high spatial resolution, continuous imaging, superior spatial visualization. There are no radiation associated with TE, as well as it is not nephrotoxic. Now we compare this TE with transthoracic echo as well as the intracardiac echo. TTE is non-invasive, readily available, but many a times certain congenital lesions it provides a poor window in the cath lab, whereas TE provides excellent septal as well as posterior imaging, but it requires sedation as well as the general anesthesia. Coming to the intracardiac echo, it is expensive as well as it needs very large sheath, and there are limited vascular access in such small pediatric patient, so it is not that much feasible comparing with the transesophageal echocardiography. Now coming to the specific pediatric cath procedures, it is helpful in ASD device closure, VSD device closure, PDA device closure, balloon valvuloplasty like aortic and pulmonary valvuloplasty. It helps in the transcatheter closure for the complex lesions. It helps to hemodynamic assessment and as well as the early detection of the complications. Now coming to the ASD device closure, it helps in the pre-device or pre-procedural role, during procedure as well as the post-procedural role. Now pre-procedural role, it is useful in the assessment of the rims as well as the whether this particular type of ASD is suitable for the device closure by percutaneous or not. Now coming to the various rims of the ASD, ASD has basically 6 type of rims, like right upper pulmonary rim, AV or mitral valve rim, coronary sinus rim, which is inferior, aortic rim, SVC as well as the IVC rim. Now in this figure we can see the aortic rim, which is anterior and superior, whereas mitral or AV ring, it is anterior inferior. Posterior superior and posterior inferior are SVC and IVC rim. Coronary sinus rim is inferiorly, whereas right upper pulmonary rim we can see in this figure. Now this TE image, in the first image we can see the 4-chamber view of the TE, and it depicts the posterior rim. In the schematic diagram we can see this posterior rim. In the second image, it is also a 4-chamber view of the TE, and we can see the AV rim, that is anterior-inferior rim. From the 4-chamber view, while we rotating the rotating the probe in the clockwise direction, we can see this right upper pulmonary rim in this third image as well as the flow across the ASD. In this image, this aortic valve short axis view, we can see the aortic rim. In the second figure, we can see this absence of aortic rim. In such type of cases, these patients are not ideal for the device closure, as the ASD device might impinge on the aortic valve. Now in this bicaval view we can check for the SVC as well as the IVC rim, which are very well depicted in this first figure. In the first figure we can see the SVC rim as well as in the second figure we can see for the IVC rim. While in the second figure we are seeing this coronary sinus rim, From the mid-esophageal four-chamber view, while advancing the probe, we can see the coronary sinus as well as the rim for the coronary sinus. Now, these are the characteristics for the ASD defect which are suitable for the anatomy for PTC. Like the ASD must be of ostium secundum type, the size should be less than 40, the septum the septum must not be aneurysmal, the rim size of at least 5 mm, and the PA pressure as well as the pulmonary vascular resistance are less than 2/3 of the systemic. Now, intra-procedural role of the T, it guides the transseptal puncture as well as the positioning of the wire as well as the sheath to monitor the left atrial disc deployment, for the confirmation of the right atrial disc alignment, and the device, and after the device closure to detect the impingement of the mitral valve, aortic root, SVC as well as the pulmonary veins. Now, during the procedure, first T helps to guide the size of the defect, which is measured by there are two tests for this. One is a static balloon diameter as well as the dynamic balloon diameter. While passing the balloon through the defect, it creates the shape. If the balloon is properly positioned through the defect, it creates the shape of this dumbbell or figure of 8. So, it shows the balloon is placed properly, and one must check for the size of the defect. While in the second figure, we can see the balloon is placed above the defect, and it takes the shape circular or oval. So, it always overestimates the size of the defect, and thus it also not useful for the proper sizing. Now, second important point for this device closure, while passing the after puncture of the septum and passing the wire and the sheath must pass through the pulmonary vein, that is left upper pulmonary vein, and not in the LA appendage, because placement of the sheath and the wire to the left upper pulmonary vein provides the better stability than left atrial appendage. Also, left atrial appendage is very fragile structure. It might lead to complications like rupture of the appendage as well as hematoma and tamponade. Now, after the deployment of the left atrial disc occluder device that we can see in the first image, the right disc that is shown here in the white arrow is appeared, and properly placed device, there is also appearance of the vest in between the two discs. Once the occluder device has been placed, after releasing of that device, the position of the device relative to the surrounding structure should be evaluated, which are if there is a residual shunt is there, whether the device is stable or not, which they usually check through the Minnesota procedures. And after that, all this impingement is ruled out, there is no residual shunt is checked out. One should check for the pericardial effusion or the tamponade. Now, coming to the VSD device closure, transesophageal echocardiography helps in identifying the type of the VSD, what is the size of the defect, assess the proximity to the valves. It guides the device deployment as well as the early complications like aortic regurgitation of the tricuspid regurgitation. Now, these 4 images of the T, which are labeled A, B, C and D, are the ideals for and showing all the types of the VSDs as well as the various views and which VSDs are shown in the which T views. Now, coming to the figure A, showing the mid-esophageal aortic valve long axis view. This image shows perimembranous VSD. Perimembranous VSD are usually near to the aortic valve. So, here the defect appears in the cross-sectional that displays the tricuspid valve and an aortic valve at the level of the mid-esophagus. So, this perimembranous VSD we can also see in the mid-esophageal 5-chamber view as well as the mid-esophageal RV inflow-outflow view. As we already discussed, this perimembranous defect are nearby to the aortic valve. In mid-esophageal RV inflow-outflow view, it appears near the 3 o'clock to the 6 o'clock position, that is near the pulmonary valve. And coming to the next, muscular VSD, the examination for this defect uses the sweep of the entire ventricular septum to identify an deficiency surrounded by exclusively by the muscular rim. This muscular VSD we can see here in mid-esophageal aortic valve long axis view, mid-esophageal 4-chamber view, as well as the transgastric basal views. Even posterior muscular VSD, which are many a times missed, can be seen by retroflex the probe. Now coming to the outlet VSD, the mid-esophageal RV inflow-outflow view is particularly helpful, which is also known as the supracrustal VSDs. It is usually nearby the tricuspid valve. So this outlet VSD is usually appeared at the 6 o'clock to the 9 o'clock position in the RV inflow-outflow views. And the outlet VSD is usual. And coming to the ventricular septal defect device closure, the pre-deployment mid-esophageal long axis view confirms the distance from aortic valve, whereas in aortic valve short axis view, it defines the cuff relation to the device. In transgastric short axis view, it helpful to check for the perimembranous VSD if there is any muscular extent or not. To check for the LV disc deployment, we usually use the transgastric short axis as well as the mid-esophageal long axis views. RV disc deployment, mid-esophageal 4-chamber as well as the aortic valve short axis views. And post-deployment, one should check for the AR, TR, if there is any residual shunt or not, to evaluate the gradient across the LVOT and the appearance of any new VSD which might be not appears before. Now, in this VSD device closure, one should always assess the aortic valve and the tricuspid valve before the device closure. One should quantify if there is AR or TR before the procedure. One should measure the VSD on the planes, all the views. One should check for any tiny muscular VSD which might not be visible on the transthoracic echo. One should watch for the new AR after the deployment of the device, and one should check the conduction system after device via ECG. TE also helpful for the PDA closure. Particularly, it is helpful in renal dysfunction child, complex ductal morphology, and residual PDA after post-surgery. It helpful in the real-time anatomical assessment, radiation detection, contrast minimization, immediate complication detection, as well as the hemodynamic assessment to check the volume overload on the left ventricle. Now the key parameters are involved: the origin of the duct, that is from the aorta as well as its pulmonary end. What is the minimum as well as the maximum diameter of the PDA? What is the shape in which classification it fits of Krichenko classification? What is the relationship to the left pulmonary artery as well as the descending aorta, to check for the LV volume overload and identify if there is any other congenital anomalies associated or not. During PDA closure, there are two important TE views. One is mid-esophageal descending aorta long axis as well as the upper esophageal aortic arch view. In the first image, mid-esophageal descending aorta short axis view, while rotating the probe clockwise and applying the color Doppler, one can see the Doppler and the turbulence near the this DTA showing the PDA. While applying the continuous wave Doppler, one can see the continuous flow across the PDA. Now post deployment, there are certain things one should check, that is residual shunt, descending aortic gradient, if there is any new gradient across the left pulmonary artery, whether the device is stable or not, or if any pericardial effusion. If device is malpositioned or disc is protruded anywhere, impinging on the nearby structure, whether there is a new onset LPA or aortic obstruction, whether there is a residual gradient across the PDA or not. TE also helpful for the valvuloplasty. Coming to the balloon valvuloplasty, pre-procedural assessment helpful for the to check the pulmonary valve morphology, like whether the pulmonary valve is dysplastic or dome shaped. What is the size of the measurement annulus, what is the size of the RV, how RV works, if there is TR or not, to assess the TR, to grade the TR, and if there is any RVOT muscle bundle present or not, or RVOT level of the RVOT obstruction. While inflation, during the balloon inflation, it helpful to confirm the balloon position across the pulmonary valve. Post dilatation assessment, residual gradient, pulmonary regurgitation severity if any new onset, or RV function as well as the pericardial effusion. Various views for TE during pulmonary valvuloplasty are mid-esophageal RV inflow-outflow view, transgastric basal view, which obtained mainly from the transgastric basal short axis view while rotating the probe clockwise, aligning multiplane angle to the 10 to 20 degrees. One can get this transgastric basal RV view as well as the upper esophageal aortic arch short axis view. This view can obtain from the mid-esophageal descending aorta short axis view while withdrawing the probe slightly after appearance of the aortic arch. Adjusting the multiplane angle to the 90 degree, one can get this mid-esophageal upper esophageal aortic arch short axis view. TE also helpful in aortic valvuloplasty, like pre-procedure assessment to delineate the valve morphology like bicuspid or tricuspid. What is the size of the annulus? How LV works? If there is any LVOT obstruction or any LVOT gradient across the LVOT, what is the baseline AR or not? During the balloon inflation, balloon alignment across the valve as well as its relation to the root as well as aortic cusp. Post-dilatation assessment of the new onset of AR or any worsening of the AR, whether there are any cusp iatrogenic injury to the cusp, whether there is a prolapse, any root injury or pericardial effusion should be checked. These all complications end during procedures. Various TE view are mid-esophageal aortic valve short axis view, mid-esophageal aortic valve long axis view, transgastric long axis view as well as the deep transgastric view. TE also helpful in various complex lesion and closure of this complex lesion like residual post-surgical shunt. Like post VFD surgical closure, there are residual shunt, there are residual VFD one can see. So it can be closed. If it is feasible, it can be closed via the in the cath lab via device. So TE helpful to detect if there is any jet, what is the level of the leaking and what is the direction of the jet. It is also helpful in the Fontan fenestration closure as well as the various paravalvular leaks. TE can helpful in the hemodynamic assessment like QP and QF estimation, VTI based calculation, function of the right ventricular to measuring the right ventricular fraction area changes, and also helpful in the measurement of the pulmonary arterial hypertension via TR jet velocity, size of the RV, grading of the TR as well as the septal flattening or not. There are certain limitations like it requires GA, there are risk of the esophageal injury, it is limited in extremely small children and neonates, there are very much difficult to insert, even insertion the probe. It is operator dependent as well as it needs additional manpower. While there are certain future direction for this use of the TE in cath lab like invention of these miniature probes, routine and easily availability of 3D TE probe, real-time imaging, AI-guided defect sizing, radiation-free structural intervention of the proper cath labs and interventions. To conclude, TE has become an essential imaging adjunct in pediatric cath lab, providing real-time anatomical as well as the hemodynamic guidance during the structural intervention. It also enhances the procedural precision by adding device sizing, deployment and immediate assessment of the valve integrity as well as the residual shunt. It also helps to improve safety through the early detection of complications such as any obstruction to the nearby structure, any regurgitation lesion or pericardial effusion as well as the tamponade. Thank you.